Hi, David Rosenberg here for the Psychopharmacology Institute. We're excited to be introducing something new that we're calling CAP Smart Takes, or Child and Adolescent Psychiatry Smart Takes. So what exactly is a CAP Smart Take? Well, first and foremost, it's short, it's quick, and clinically relevant to all of you who treat various childhood onset psychiatric disorders, from child and adolescent psychosis to OCD to eating disorders, bipolar disorder, depression, anxiety, autism spectrum disorder, and many more. I hope I'm not leaving any of your favorites out. The goal is not to be encyclopedic, but short, to the point, big picture, give the key points that are most clinically relevant and that may suggest newer alternative approaches to a particular childhood disorder. We are not going to go into detailed methodology. This isn't an ivory tower with armchair theories. We're going to drill down on what can immediately inform your practice and hopefully provide some innovative strategies that can improve the outcome of the children and families we serve. We know that children and adolescents with psychiatric disorders remain diagnostic and therapeutic orphans, and far too many receive limited or even inadequate care. Let's see what we can do to change that. Hope you enjoy these CAP Smart Takes, and please pass on suggestions for topics you'd like us to cover and discuss. All the best, and let's get to it. In this CAP, or Child and Adolescent Psychiatry Smart Take, we'll take a look at a concise, elegant review of adolescent depression by Drs. Miller and Campo, recently published in the New England Journal of Medicine. Now, do we even need another review of adolescent depression? Well, if it's written by Drs. Miller and Campo, the answer is a resounding yes. And it's no wonder that the New England Journal of Medicine decided to devote a special focus to depression in adolescents. We know that rates of depression have increased significantly across the lifespan, but they're skyrocketing in adolescence. We also know that the rate of increase of depression in adolescents is significantly greater than in any age group. Suicide is now the second leading cause of death among teenagers, and the most common underlying cause of suicide is depression. We also know that since 2004, the FDA issued its black box warning for antidepressants in youth, raising issues and concerns of potential suicidality associated with using antidepressants in youth. So it's very timely now to examine where we were, where we are now, and where we need to go. We also know that most adults with depression experience their first depressive episode in adolescence. And depression in adulthood is often predicted by early depression or anxiety. Now, one key issue is, are the antidepressants in adolescent depression associated with increased risk for suicidality? And this is something I remember keenly because when this was getting national attention around the world, where there was this concern that the SSRIs like Fluoxetine and others were no better than placebo. And that was a big question. What is the placebo response? Because it seems so high. And there weren't always delineations or discriminations between medication and placebo. And there started to be this concern with some studies that was there an increased risk of suicidality, suicidal ideation, suicide attempts in adolescents treated with SSRIs. And I was actually doing a study funded by the National Institute of Mental Health where we were using Fluoxetine in children and adolescents. And at that time, the National Institute of Mental Health insisted that we stop using Fluoxetine in our studies and use a different SSRI. Some of you may remember that in the United Kingdom, they stopped using all SSRIs except for Fluoxetine. So a number of questions remained unanswered. And this suicide concern obviously is something very concerning in the pediatric setting. What we know now is that there were meta-analyses of several treatment trials analyzed by the FDA that found a small but statistically significant difference in suicidal ideation and attempted suicide in adolescents treated with antidepressant medication versus placebo. But what I want you to remember is that none of these studies included suicide-specific measures. They all relied on reported adverse events, and all were post hoc analyses. That means the study of suicidality was done after the fact, not longitudinally or in real time. Now, what's interesting is that more recent investigation using suicide-specific measures found absolutely no difference in suicide risk between adolescents receiving antidepressant medication or placebo. And finally, it's important to examine the different populations treated with antidepressants. Because in adolescents with depression, where this first link was possibly found, this wasn't seen when the SSRIs were used in placebo-controlled treatment trials of adolescents with social anxiety disorder, with obsessive-compulsive disorder, or with any disorder other than primary major depressive disorder. One other thing to keep in mind is that the placebo rate, which is often especially high in adolescent depression, appears to be much lower in federally funded studies than it is in industry-funded studies. And our team had the honor of being one of 16 sites designated to participate in the National Institute of Mental Health Treatment for Adolescents Depression study, the TAD study, which found a much lower placebo rate than was found in industry-funded studies. And all of the sites on the TADS trial were academic university sites. So that's one thing to look for in studies comparing placebo and medication. In the TADS study, consistent with other studies, we also found that the most effective treatment was fluoxetine plus cognitive behavior therapy, which beat placebo alone, beat cognitive behavior therapy alone, and beat medication or fluoxetine alone. And one other interesting thing is that there may be a protective effect against suicidality when you combine cognitive behavioral therapy with medication treatment, and it might result in your being able to use a lower dose of SSRI. So a lot of advantages, like in diabetes, where we often would use a biological treatment, insulin, as well as a psychosocial treatment, diet or exercise. Here in depression, the biological treatment is the SSRI, and the psychosocial treatment is cognitive behavioral therapy or other psychotherapies. Now, we still don't know why there is this difference with other antidepressants, the tricyclic antidepressants that are FDA approved in adults with depression, but have consistently been found to not be superior to placebo in child and adolescent depression. And to date, there still are only 2 SSRIs or antidepressant medications FDA approved in youth with depression, fluoxetine and escitalopram. And fluoxetine is the only FDA approved medication in youth for both children and adolescents. So there's a lot of work that still needs to be done. I think this article gives a wonderful overview of where we are, what needs to happen going forward, and how we get there. I would have liked if it had talked a bit more about alternative treatments in terms of pharmacogenetics, diet, nutrition, novel agents such as ketamine, transcranial magnetic stimulations, electroconvulsive therapy that at some centers has been used for treatment-resistant depression. But it doesn't detract from a meritorious and worthwhile read for all of those interested in adolescent depression.